Hello and welcome to another episode of our podcast. Today, we're tackling the important topic of infertility treatment. Did you know that infertility affects 8 to 12% of couples of reproductive age worldwide? Joining us today to shed light on this issue, we have with us Dr. Ankita Goel, an esteemed gynecologist and an IVF specialist. Dr. Ankita's dedication to her field is evident through her numerous awards, achievements, and contributions to research and academia. She is also a proud member of Federation of Obstetric and Gynecological Societies of India. With over 14 years of experience and a wealth of qualifications, Dr. Ankita is here today to discuss the various modes of treatment available for infertility. So, Dr. Ankita, it's a pleasure having you with us today.
Thank you, Hiti, for the kind introduction.
So, to start with, could you share your medical journey with us?
So, yes, I started my MBBS in 2005 from Government Medical College, Nagpur. After that, I have done my post-graduation from BMMC and Safdarjung Hospital in Delhi. So, I did my post-graduation in obstetrics and gynecology. So, Safdarjung is one of the most busy hospital of Delhi. And after that, I worked as a resident doctor in oncology department for a period of almost 9 months. And then somehow I switched to infertility, and I have done my fellowship by National Board. That is a 2-year course in infertility in one of the most prestigious, institution of infertility in India. That is Milan, Bangalore. So it was under Dr. Kamini Rao. So yes, this is in short my journey.
Thank you for sharing your enlightening journey. And let's begin with our discussion. What initial steps would you recommend for patients embarking on their fertility journey, considering the multitude of treatment options available for infertility?
See, the first thing what a patient should do is they should consult a fertility specialist. Ideally, if a couple is not able to conceive within 1 year of their married life, or if the couple is more than 35, especially if the female is more than 35 years of age and she's not able to conceive within 6 months of her married life, then they should be consulting a fertility specialist. A fertility specialist will take a complete history, which will include everything: their menstrual history, their sexual history, their medical history, surgical history, and treatment history. All kind of histories will be taken. In the evaluation. Ultrasound is very vital part of any fertility treatment, because ultrasound is as good as a stethoscope for a physician. So we take many decisions based on the ultrasound. So if the ultrasound, it will tell us like how is the uterine health, how is the ovary looking like, how many follicles we are looking at. So this is what all we see in ultrasound, because that is the place where the baby is going to implant, the embryo is going to implant. Okay. So, and also, some blood tests might be advised to them. Now, this is the female part. Okay. Also, some females might have to undergo a tubal test based on their history. Okay. So now, regarding males, see, the 50% onus is on the males also. So for them, a semen analysis has to be done. Now, when we see all the parameters, and then we take a collective decision, a fertility specialist will guide the couple based on their history, based on their investigation, and they also what treatment they have taken earlier. Okay, so based on all these factors, a fertility specialist will dictate the next plan of treatment for them. So this is in short a person, a couple will have to go through their planning for their fertility journey.
That was quite informative, doctor. Now, can you tell us how does a patient's medical history, which includes factors like age, previous reproductive health issues, and any underlying conditions, influence the choice of infertility treatment?
So, see, medical history, if a patient is having hypertension, or if she, the case of uncontrolled diabetes, or maybe thyroid. Also, some patients who are having very high level of prolactin. So sometimes all these factors can affect your fertility at certain level. Sometimes nowadays, it has been seen that deficiency of vitamin D, it also affects the oocyte quality. Okay, so these are the factors which we look at when we are treating when we are looking at the medical history of the patient. Also, if there is some infection, history of some infection, like if a patient has suffered from tuberculosis, or maybe some severe infection which could have affected the tubes of fallopian tubes of the patient. So this becomes very vital when we are treating a couple. Okay, because if there is a tubal factor involved, the treatment plan completely changes. Okay, if the thyroid is uncontrolled, the patient can might conceive, but then she might undergo a miscarriage also. Okay, diabetes can lead to neural tube defects in the baby. So all if the prolactin is very high, so in such cases the patient they do not ovulate properly. The follicles do not form properly. So all these factors are very important when we are looking at the medical history of the patient. Now talking about the age, see, as the age increases, the quality of the oocyte as well as your ovarian reserve, they both fall. Okay, they both decrease. So if a female is more than 35 years of age, so the chances of getting a healthy baby slightly decreases, and chances of getting an anomalous baby increases. Okay, so yes, we advise the couples to conceive, if they can conceive well in time, good for them. Also, in case not possible because of their job or for whatsoever reason, because of late marriage, at least if they can freeze their oocytes, if they can freeze their eggs, so that will that makes them quite secure in they can plan the pregnancy as per their wish later on whenever they are ready for that. So yes, age affects the outcome of the pregnancy very much.
So that was also very informative regarding all the factors that you had you. Could you discuss the role of gonadotropins in stimulating ovulation and improving fertility in both men and women? And how do they differ from medications like clomifene? And what can be the potential side effects for these?
So see, clomifene or letrozole or tamoxifen, these are called as oral ovulogens. Basically, these are medicines which increase the hormone level in our body only. Okay, the hormone level rises, it helps in the formation of the follicle. But when that is insufficient, or maybe just to supplement to increase the follicular growth, maybe the number of follicles, we sometimes supplement injection, HMG, gonadotropin injection, in the form that we give them directly. Okay, so we supplement them in cases of probably if a patient is undergoing probably a natural cycle, they are going or maybe a IUI cycle. In that case, we might supplement the oral ovulations with gonadotropin injection just to have a multifollicular response, or maybe to increase the growth of the follicles. Okay, and sometimes like in IVF cycles, again the intent of doing the IVF cycle, Hetri, is mainly to get the maximum yield. The maximum follicles we want that they should come out, because every oocyte increases the chance of pregnancy. Every oocyte will become an embryo, and therefore we have a good chance of getting pregnancy. So in IVF cycles, we are using gonadotropin injection daily, on a daily basis, so that we get a multifollicular response and we increase the chance of getting pregnancy for the patient. In some cases like hypogonadotropic hypogonadism, it becomes a medical indication. We have to supplement the gonadotropins because there are no hormones in the body. Okay, even if we give oral ovulation, those medications are not going to act only. Okay, so in such cases, like especially a case of hypo, we have to supplement the patient with gonadotropin only. Now this was the female part. Now talking about the males, in males also similar condition, like some cases of oligospermia, like where the count is low, or maybe similar case of a hypo, we have to supplement the males. We have to supplement gonadotropin. We have to give them gonadotropin, and that improves the semen analysis of the patient. So that helps in the better outcome of any kind of fertility treatment. Now you asked about the potential side effects. So yes, first thing, gonadotropins are given in injectable form. Number one. Number two is they are expensive. Number three, they can they require a very I'll say regular monitoring. Like when we have just given oral ovulation, So the chances of a patient going into hyperstimulation is very less. But when we are giving gonadotropin injections, when we give, we have to follow the patient, little meticulously, so that she doesn't develop any kind of complication. Okay, Hetvi. So these are the things, and yes, also gonadotropin increases the chances of a patient going into hyperstimulation. Hyperstimulation is nothing but excessive hormone in the body. It is usually seen in a case of PCO patients. The patients who are suffering from PCOS, they are at more risk of developing a hyperstimulation syndrome. So yes, gonadotropin increase that also, but usually nowadays, the doctors are very aware of this complication. They take proper measures to prevent it. So as I told you that yes, when we give the injections, we have to meticulously follow. We have to meticulously, do the scans and look for any kind of hyperstimulation. So these are the things difference between gonadotropin and oral ovulation.
So that was very interesting and enlightening response. Now, coming to the next question, can you discuss any recent advancement or emerging technologies in the field of infertility treatment and how they are changing the landscape these days?
So, see, the first thing is I like to tell about the recent advancement. It's not very recent. It's like definitely more than 15 years old now. So, one thing is intracytoplasmic sperm injection. So, there are two types of IVF basically. One is conventional IVF and one is ICSI. We call it ICSI. So, where the sperm count is very low. In males, where the sperm count is very low, even if we are getting the sperm directly from the scrotum, maybe there are some procedures where we have to, the sperm doesn't come out, we have to take out by injection, so that is a different procedure. But in such cases also, ICSI is one of those where the sperm quality is very poor. We still have the hope of getting embryos. Okay, so patients who are having probably obstructive azoospermia, okay, or whose sperm count is very low, है ना? So all such conditions, they ICSI is very beneficial for such patients. The second thing is nowadays we are having automated sperm analyzer. So it has its own pitfalls, okay, but for cases, for centers where we don't have a experienced embryologist, usually like in all good reputed centers, at least a junior embryologist does the sperm analysis, okay, that gives a reliable value. But where such facilities are not available, the automated analyzers, sperm analyzers are very beneficial because it decreases the dependency on the human. The human errors are less. Also, it increases the it's an objective report, right? So the count and the motility part is told very. I feel it is good. The values are good. So this is one of second new thing which I can remember right now. And the third is, I'll say, pre-implantation genetic testing. So this is basically earlier when IVF was not there. Usually, a couple who has a history of genetic disorder, there was nothing, right? Nowadays, if there is some genetic disorder in the family, okay, and we have to screen the embryos for those for that genetic disorder. So there is some test called as pre-implantation genetic testing. So rather than doing it when the female has already conceived, and if found to be positive, going for missed abortion, basically, what we do is we form the embryos and we do the testing on those embryos, and we screen the embryos that these are the affected ones and these are the healthy ones, and we do the transfer of only healthy embryos. Okay, Hetvi. So that way, the emotional trauma a female goes through of carrying an abnormal baby and later going for miscarriage definitely decreases. So pre-implantation genetic testing has a lot, it has a huge this thing. It's altogether a very separate topic. It's a huge topic, but yes, that is also one of the most I would say beneficial new thing in fertility treatment.
That was very fascinating. Finally, are there any myths or misconceptions surrounding infertility treatments that you would like to address?
So the first is many patients, they meet us for the first time, and nowadays many time patients have already heard about IVF. They know, they have at least heard about it. Even if they don't know the exact procedure or whatever, but they still have heard about it. Many times patients feel, one of the most common misconception is they feel that if a patient undergoes IVF, so she will be bedridden for whole of her pregnancy. That is, this is not true at all. See, we don't ask any patient to be bedridden. That is actually not healthy also, because it can lead to its own sets of complications like blood clotting and all. So if a patient, it depends, it varies from patient to patient. Like if a patient has any kind of complication, like probably if she has some bleeding during her pregnancy, so then it is natural for a doctor to tell her that you have to rest for some time. But it is not true for all. It is only for a very few cases who actually develop this kind of complications. Second misconception is, Hetvi, that all the patients who undergo IVF. See, definitely yes. When the egg retrieval is being done, they get multiple injections. But no, when the pregnancy is there, it entirely, the medication which they will receive during the pregnancy or after the embryo transfer, it entirely depends on their medical history. It is not, it doesn't depend, it is not common for all, I'll say. It is not that every patient will receive the same kind of injections or same kind of drug. No, it is not like that. Okay, so this is another one. And third one is, I'll say, some people think that IVF, babies who are conceived through IVF are not genetically normal. So this is not at all true. See, the thing is, there are some, because the thing is, definitely, whatever a parent is carrying, infertile, if a couple is infertile, right? So definitely there must be some reason that they are not able to conceive. So whatever the parents are carrying, unless we do a genetic testing or unless we go ahead for all those screening, so the baby is bound to carry all those things, right? So it is like that only. It is not the risk of, I'll say, abnormalities in babies conceived through IVF is roughly around 2 to 3%, which is common for natural, which is same for naturally conceived babies also. Okay, so this is the third misconception which I can think of right now, and I'm sure there must be others also right now.
Thank you so much, Dr. Ankita, for sharing your expertise and insights on this sensitive topic of infertility. It's been a pleasure having you with us, and we will be looking forward for more such insightful and interesting discussions in future. And as we continue today's podcast, I'm grateful to our audience for taking the time to tune in. And if you're a healthcare professional with questions or an interest in exploring more medical topics, remember to connect with us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. Until we meet again, take care and stay well.